Can everyone see my screen okay right now?
Yes, we can. I think might be a little bit of echo, but we see the screen.
All right, everyone. Well, we will go ahead and get started today. Thank you so much for joining us today for our first HIV ECHO session. So my name is Heather Sorella, and we are the University of Nebraska Medical Center Specialty Care Center. And thank you so much for joining us today. Our first HIV ECHO session is titled HIV 101. And today's subject matter experts are Dr. Netta Fadul, Dan Cramer, and then we have some guest subject matter experts, Laura Krajewski and Nakia Boker. And then I am the HIV ECHO facilitator. I'm kind of like the back end little wizard, just sort of putting the things together. And then just as a fun little tidbit, but our ECHO sessions will be held on the first Thursday of every month, except January and July of 2025. Alrighty, and then this is just a little agenda for us to go over. But thank you again so much for joining everyone. Dr. Fadul will be presenting HIV 101 today, which is going to cover a couple fun different topics like HIV epidemiology in Nebraska, the history of HIV, some tidbits about HIV testing, and a whole lot more. And then Dan Cramer will follow to present today's case study, and we will stop recording at that part of the session. And then Nakia and Laura are here to offer any sort of little extra tidbits of wisdom. And they are two people who have a lot of experience in this field. And I think they will have a lot of fun tidbits to share. And we're just really big on discussion. So any comments or questions in the chat, feel free to just pop them in there. Alrighty, and then just some housekeeping reminders. But we love discussion, so feel free to throw anything into the chat. But please stay muted unless you are speaking. And then we would love to see your face, but totally okay if you're not able to have your camera on right now or anything. And then sessions, like I said, the first half will be recorded, and then we will have those links available later. And then we do have a feedback survey that I will put in the chat near the end of the session. If you all wouldn't mind filling that out, we would greatly appreciate that. And I'll hand it on over to Dr. Fadul now.
Thank you so much, Heather. Really excited to see everyone. We have been brainstorming and thinking about this program for a while, and I'm really glad to see it come to fruition finally. So this is our first session. As Heather mentioned, we will have 12 sessions over the next year. The goal of this program is to improve health outcomes for HIV care and prevention in the state. And we all, I think, agree is that if we can prevent HIV, that would probably be the biggest bang for our buck, instead of waiting till patients are diagnosed with HIV and trying to make sure they get the treatment that they need. So I'm going to go ahead and just move on to the next slide.
Sorry about that. Can everyone see my screen okay? I'm so sorry.
Yeah, we see it. If we could just go to the next slide, that would be wonderful. I think it's not moving still. Oh, there you go. Okay. So I've been doing HIV care for about over 10 years now. And I would really like to just kind of instill some passion for HIV prevention and care in our audience today. And we're going to start very simple. We'll describe the origin of HIV, the history, list the major modes of transmission. We'll talk about the HIV life cycle and how does that relate to testing and prevention of HIV in the state. I'm hoping by the end of this session, you'll go to your colleagues and say, there's a wonderful program about HIV at the University of Nebraska. Please go ahead and register and join. So we'll rely on you all, but also if there's any feedback for how we can improve this program, please feel free to share that with us. Next, please. So for many of you in the HIV field know this already, but for those who are new or want more information, the first case actually of HIV was described back in 1981, but we think HIV has been in existence probably since 1920. The origins have been traced that long. And the first description was this unusual cluster of cases of weird pneumonia, which now we know as PJB, pneumocystis Giardia pneumonia. There was also cases of Kaposi sarcoma, which is related to a virus that can cause skin disease and skin cancer. And this happened in a previously healthy, at the time they called them homosexual men, but gay and bisexual men. And the disease was termed at the time gay-related immunodeficiency disorder. And that is really important because that actually led to the historic stigma and stigmatization of HIV and the populations that is impacted. So that naming was completely inappropriate at the time. And unfortunately, that led to where we're at today. 40 years later, we're still trying to figure out how we can prevent this infection. 1983 was the first time that GRID at the time, because we didn't know if it's a cancer, if it's an infection, what's really causing this problem. 1983 is that when we figured out this is actually a virus. And it wasn't until 1985 when we developed serologic testing for HIV. And if you compare that to what happened now with COVID, it really didn't take it that much, maybe a month or so before we figured it was a virus, and a couple of months before we were able to test for it. But back then, because the science was not as advanced, it took us about 4 years to get to that point. And it wasn't until 1987 that was the first antiretroviral AZT was actually introduced. And AZT was already there. It has been tested for cancer back in the 1960s. It wasn't found to be effective against cancer. So it's kind of put on the shelf. It wasn't really used until 1987 when scientists started experimenting with it for HIV, and they found it to actually be effective. 1996 was a major breakthrough in the history of HIV because that's when HAART, which we now know as combination ART, became available. And that's when scientists figured out that you need to combine medications together in order for them to become effective and in order for the virus not to develop resistance. And that was the introduction of HAART into the market. And only 4 years later, mortality from HIV, AIDS, and AIDS-defining diagnoses, cancers, infection went down by 80%. And again, that was a major breakthrough in the history of HIV, that pretty much before that, anyone who got diagnosed with advanced HIV or advanced AIDS had a high risk for mortality within 6 months or so. But with introduction of HAART, that mortality decreased by 80%. So next slide, please. So what is HIV? As I mentioned, it took us a while to figure out this is a virus, and it's a very unusual virus. It's a retrovirus, meaning that it gets transcribed from an RNA to a DNA. Generally, the genome of humans and other creatures, moves from DNA to RNA, and then the RNA makes proteins, and the proteins are what makes everything in our body pretty much. But in the case of HIV, it gets transcribed backwards. So the RNA actually makes DNA, and then the DNA will make RNA, and that's why it's called retro, because it goes backward. There are 2 types of HIV. I'm not going to bore you about the details, but just know that the one that we have here in North America is HIV-1, and subtype B specifically is the one that's dominant here and in Western Europe. HIV-2 is predominant mostly in Western Africa, and it's really restricted to that area. The reason it gets introduced sometimes into the US is now because of migration and movement of people around the world. That's why we see HIV-2 in other parts of the world, but it does originate in West Africa. The good thing about HIV-2 is that it's less pathogenic. It doesn't cause as fast deterioration in the immune system like HIV-1 does. So let's go to the next slide, please. So let's talk a little bit about HIV epidemiology. We'll start kind of broadly and then go back to our own surroundings here in Nebraska. So let's go to next slide, please. So this is what's happening in the US. Now, globally, just so that you know, HIV impacts about 36 to 38 million people around the globe. And the majority of those people, 70% of people impacted with HIV, are actually in sub-Saharan Africa. And only 12% of the world's population actually lives in sub-Saharan Africa. So there is a huge disparity there about where HIV is present in the world. But even if you come to the US, there is also huge geographic disparity in where HIV is spread in the US. And in the South, particularly, the rate of HIV is pretty high. It's 14.7 per 100,000. In the Midwest, as you can see from this slide, we have a low rate, but that's also very spotty and very regional. So not all the Midwest has a low rate. So that's very important to keep in mind, is that there is geographic differences and geographic disparity where HIV actually exists in the US, but also in our region. Let's go to the next slide. So in terms of HIV in the US, there is about 1.2 million people now living with HIV in the US. It is estimated that about 13% of those people, and this is a very large number, right? 13% of 1.2 million do not even know that they have HIV, which is a big problem because those are people who are spreading HIV without knowing that they actually have it. And there is now the end HIV epidemic, which is a mandate that came from the US administration to decrease the number of people who don't know HIV status by 5%, to make it 5%, from 13% to 5%. So the goal that 95% of people know their HIV status, whether they have it or don't. 95% they get linked to HIV care, and 95% actually become virologically suppressed, or their HIV becomes under control. Now, it is estimated that every year we have about 30,000 people newly diagnosed with HIV in the US. And that's also a very large number, really unacceptable number, knowing that now we have tools to prevent HIV from happening, but we still have about 30% of people that newly diagnosed with HIV in the country. And if you look at those who get newly diagnosed and who are living with HIV in the country, there is a huge racial and ethnic disparity as well. So the majority of those who get diagnosed with HIV are from racial ethnic minorities. Black African Americans specifically are highly impacted by HIV, but even within the Black African American population, there is huge gender and sexual orientation disparity. So Black, gay, and bisexual men tend to bear the highest risk of HIV in this country. And that just speaks to the amount of stigma and amount of social injustice that we have right now towards that population that leads them to being highly impacted by HIV. And that's followed by Latinx or Latino male who are gay and bisexual males. And then that's also followed by white gay bisexual men. Now, the CDC terminology for this is men who have sex with men, because that's the actual risk factor, but generally that population we define as gay bisexual men. Next, please. And the trends have changed over the years. So some age groups are actually now becoming more impacted by HIV, specifically the younger age groups. So people who are about 25 to 40 some years of age. But nonetheless, the older age groups are still quite impacted by HIV. So the incidence has not decreased in those people. Even people who are up to 65 or up over 65, the incidence has been stable, meaning that we have not made great progress in decreasing the risk of HIV in that population. So let's go to the next slide. So when it comes to Nebraska, so there is about 2,400 plus people living with HIV in Nebraska. And the prevalence rate is about 147 cases per 100,000. And prevalence is the number of people living with HIV. Now, the incidence is a new diagnosis, which is about 7 cases per 100,000 in the population. Now, about 0.3% of people living with HIV in the US actually live in Nebraska. So it's not a high number, but it's still high enough considering the overall population of Nebraska is about 2 million or so. So this is still a very high rate of HIV, and it differs by region, as we mentioned. Similar to the rest of the country, our highest risk group is gay bisexual men. Male to male sexual contact is a higher risk of transmission, like the rest of the state, but we also have a high burden of injection drug use here in the state, as you all know, and that tends to lead to a high rate of diagnosis, but also prevalence. The diagnosis has now increased over the past few years in that group specifically in injection drug use, but also men who inject drug, we have seen a higher incidence in the past few years. Now, if you look within, next please. Within the counties in Nebraska, our #1 county actually in terms of new diagnosis is Hall County. Many people think it's Omaha, around the Omaha region, but it's not. It's actually Hall County. That's #1 county in terms of new diagnosis of HIV. And that county also has a high prevalence of HIV. That's followed by Buffalo County, Douglas County, Lancaster, and Sarpy County. So Definitely the Omaha and surrounding area has a very high rate of HIV, but the incidence, especially new diagnoses, are rising in rural Nebraska. And that's something really important to keep in mind because we need to do a better job preventing HIV in rural regions. If you have friends who live in rural regions, please encourage them to attend these programs because that's really how we're going about preventing HIV in that area. So next, please. So in terms of what is the risk for HIV transmission? So obviously, HIV is a virus that lives in the blood. It gets transmitted through blood contact. Blood transfusion is really the highest risk of HIV transmission. And this shows you the risk for 10,000 exposure. So if you have 10,000 exposure, 9,250 of those will actually transmit HIV. And nowadays, because of the amazing work we're doing screening blood, even screening blood for the HIV virus itself, not just the serology, that leads to the transmission through blood contact being almost zero nowadays. So even though the risk is really high, but we don't see that very often because of the screening we're doing for blood. And that just shows you if we go about preventing things, we're able to prevent them if we're intentional about doing that. Now that is followed by sexual contact, and in this case, receptive anal intercourse is the highest risk for HIV transmission among the sexual contact. And this doesn't matter if it's a male or female, as long as it's the receptive anal intercourse, the risk of HIV is extremely high in that group. And that is followed by needle sharing during injection drug use. So in absence of safe needle exchange programs, that tends to increase the risk in people who inject drugs. Let's go to the next slide, please. So the other risk factor for HIV that we often don't talk about is social determinants of health. So it's not only about the biology of the virus and how people inject the virus, etc., but it's also about the surroundings that impact people's life that lead to them being at high risk of HIV. And these are named social determinants or social drivers of health. And these are the conditions in the environment that affect wide range of health-related things, such as employment, education, access to healthy food, access to food in general, economic stability, neighborhood and built environment. Are you living in a neighborhood where you can actually go and exercise safely? Are you at high risk for gun violence? All of these things can actually impact the risk of HIV, and that's why we're seeing these disparities, because the population that tends to have the poorest social determinants of health are the minoritized population, racial, ethnic minority, rural population, and that's why we're seeing the rising incidence in those regions. So next slide, please. So in terms of the pathogenesis of HIV, I'm not going to spend a lot of time because there is a lot of medical jargon when you talk about the pathogenesis, but I'm going to try to simplify this my best. So let's go to next slide. So why is HIV so dangerous? HIV is a dangerous virus because it attacks the immune system. Our immune system is our defense against viruses, right? So when you have a virus that attacks the defense against it, you basically kind of lose your ability to control that virus unless your immune system kind of just goes through this massive transformation to be able to attack HIV. And it's not one of the viruses that you get exposed to early in life. So for example, flu and adenovirus and CMV and all of those things, you get exposed to them early in life. So you kind of build some memory to them. With HIV, you don't really have a memory. So when it attacks the body has not seen this virus before. So it really just impacts it quite a bit. And the other niche about HIV is that it actually integrates itself inside the human genome. So in the middle of this slide, in the middle of this diagram, you see the DNA of the human genome, and the yellow piece there is the HIV virus. So it's magical. It brings its own enzymes with it. It brings that reverse transcription enzyme. It brings another enzyme called the integrase, and the integrase enzyme basically cuts the human genome and inserts HIV virus inside the genome. So it becomes part of the cell, and whenever the cell replicates, it makes more HIV viruses. And that's why there are millions of viruses produced in the body every day if we don't give the body treatment to prevent that replication. So let's go to the next slide, please. So with that, now when the body is first exposed to the virus, as I mentioned, it reacts to it really massively. Most of the time, people get what we call a flu-like illness. So it's either flu-like or mono-like because your body is going through this inflammation. you get fever, you might get a rash, you might get a sore throat, you might get lymph node swelling, and that's basically showing that the body's reaction to the virus. But the problem with that is that it mimics so many other things, so that sometimes your body's, you know, as a physician or healthcare providers, you're not able to tell, is this a flu? Is this mono? Is it something more concerning and more serious than that I need to be concerned about? And during that time, the virus spreads in the body really massively. It's in the millions around the body, and it takes a while before the human body is able to make antibodies because we don't have memory to it, remember? So it takes us about 6 weeks to make antibodies to bring that viral load down. And you see that in the green dotted line here. This is the viral load in the body. So it goes up to millions and then decreases after a few weeks to where it's where we call the virus set point. And that's where it stays pretty much for the whole time until we introduce medications to control the virus in the body. But if we don't test for HIV, we're not going to know that this patient needs medication. And this is unfortunately where we miss most people during that what we call latency period, because people don't have any symptoms during the latency period. They have symptoms in the beginning, but the symptoms mimic every other virus that's out there. And then they go into this latency period, which lasts years. It can last up to 10 years before somebody actually now has advanced HIV. And during that latency period, don't be fooled. The virus is not just sitting there doing nothing. It's actually destroying the human immune cells during that time. It's eating up the CD4 cells and using them as a factory to make more viruses. So even though the virus set point is set, like it's usually around the same number, but it's not sitting down, not doing anything. And the body made enough immunoglobulins and other mechanisms for defense to be able to keep it at that set point, but it's not enough to completely eliminate it because, again, it's integrated into the human genome, so it's not able to completely eradicate it. Once we reach a stage of AIDS, which is advanced HIV, by that time, the CD4 count is very low. It's less than 200 cells. And the normal CD4 count is about 500 to 1,000 cells per microliter. So when it gets to 200 cells, the immune system is so weak, and it's at risk for these, what we call opportunistic infections. Is the things that live in an environment that we usually don't react to, don't cause an infection. We kind of are able to manage them, but we don't have immune cells at that point. These infections, which usually we manage them very well by our own immune system, become opportunistic and can affect the body really badly. And we'll talk a little bit about that later, but if we don't treat HIV at this point, the person is at really high risk of death because of these opportunistic infection. Later in life, people can develop neurologic manifestations. You know, they can become even demented because of HIV spreading all over the body and affecting the brain function as well. So let's go to the next slide, please. So the host response, as I mentioned, is non-specific, and it fails to control the viral infection completely and eradicate it. And it does escape the immune system because HIV is very rapid in mutation. So the initial virus that enters the body is not the same virus that's there 10 years ago. It mutates very rapidly because the reverse transcriptase, the enzyme that HIV brings with it, is not really good at avoiding errors. It has a lot of errors, so there is a lot of mutation that happens. And the immune cells, as I mentioned, already go down, so that affects our immune system as well. So let's get to the next slide, please. And we'll skip this slide. It's just there for your information if you want to know more about the immune defense, CD4 and other enzymes, but let's go to the next slide, please. So the take-home points is that HIV has a long latency period. The CD4 cells decline very rapidly, about 50 to 100 a year. And the HIV viral load, that's another measure that we check when we're monitoring patients with HIV. We check the CD4 count and we check the viral load. And it's important to remember those two things if you're going to be in any contact with patients with HIV, because you want to make sure they're getting those two numbers monitored, especially their viral load, because that's how we can tell if they're taking their medications or not. So even if you're not in an HIV clinic, but you have patients with HIV in your setting, getting primary care or getting STI testing, whatever, it is important to check and say, when have you had your viral load check? When was the last time you had that check? Because if they didn't get a check, that means they're probably not in the healthcare system getting HIV treatment, and they might not be taking their medication. And HIV viral load is really the biggest predictor of CD4 decline. The higher the virus set point, the more likely the CD4s are going to decline quickly. So if somebody's viral set point is 100,000, their CD4 cells are going to decline much faster than somebody's viral set point at 1,000. So keep that in mind. it's important to know what those numbers, what they mean as well. So let's go to the next slide, please. So HIV testing, that's really the most important take-home point here, that everyone should get HIV tested. The CDC recommends 13 to 65 as the age group that should get an HIV test, but we had seen many people over the age of 65 who got newly diagnosed with HIV because they were missed 10 years ago. And it doesn't really matter what your age, because we know older adults are sexually active. We prescribe Viagra for older adults. That's the population that most likely to get a Viagra prescription from a primary care doctor. So what are they doing with that prescription? They're actually are sexually active. Therefore, they're at risk for HIV. So everyone deserves an HIV test. Everyone should get an HIV test, regardless of their sexual exposure, regardless of whom they're having sex with. And also regardless of their age and background. And routine HIV testing, routine opt-out testing is really the way to decrease that number of people who don't know their status, the number of people who need to be in HIV care and taking their medication, and to also prevent spread of HIV to others. Because people who do have control of their HIV, their viral load is undetectable, they do not transmit HIV to others. Now we know HIV undetectable means untransmittable. There is a big movement called U equals U. And that's why it's so important to test people, because that's the start of whether we need to treat that person become undetectable or whether we need to give them medication or other means to prevent HIV. So you should not really limit yourself to risk. I don't like the connotation of risk because it brings negative connotation, because it's not really only behavior. There's so many other factors that impact that risk. So I think if we just go about routine screening, opt-out screening, that will make life easier for everyone. So let's go to the next slide, please. So just a random question, feel free to put your answer in the chat if you're comfortable. If you're not, that's perfectly fine. But we would like to just get a sense of whom we're talking to. How many HIV tests have you had done in the past year? 0 is perfectly fine because that's why you're here, to learn more about what to do about that. But if you're doing a lot of HIV testing, we'd also love to hear from you, because we can also learn from you how you're doing that. So please share in the chat how many HIV tests have you done in the past year. And while you're doing that, oh my God, 100 to 150, awesome. So again, if you haven't done any, please share that, because we really want to emphasize how we can make this easy for people to test for HIV. That's really our primary goal from this session. So let's go to the next slide, please. So we'll talk a little bit about clinical presentation, but I really want to move forward to our case discussion, because that's the biggest outcome that hopefully we'll get from here. So as I mentioned earlier, the virus enters the body. The body has this acute reaction, which is called acute HIV. And now the terminology is primary HIV infection. And the reason we say that is acute things usually last days, but primary HIV infection can actually last a long period of time. We had seen people come to the ER over and over with fever, diarrhea, nausea, et cetera, and it can actually go up to 6 months after the person contracts HIV that they still have those symptoms of primary HIV infection. After that, the person seroconverts, and that usually happens around 6 weeks. Seroconversion now means you develop antibodies to HIV, and that's actually the time when we can tell somebody has HIV infection from routine screening, because routine screening checks for antigen against HIV, or antigen from the HIV virus, but also checks for antibodies. And depends on the lab test that you're using, you might be checking for both actually. And then the clinical latent period that I talked about, where nobody has any symptoms, you can be missed, you may have a little bit of lymph nodes and fatigue, but later towards the end of that clinical period, people start getting wasting, they start getting more tired, they lose weight, and that's usually what happens. That's how we catch them. Somebody thinks that, oh, maybe this is HIV, and test them, and we find that that's what's happened. Early symptomatic HIV, that's when the weight loss and the early symptoms happen, and AIDS is a little too late. By the time they have AIDS, it's a little too late to actually prevent that patient from having poor outcomes, because the lower the CD4 count, it's really hard to recover that CD4 count and bring it back to normal again. Now, advanced HIVs, that's the risk for mortality and hospitalization. People are usually in the hospital at that time because their CD4 count is very low and they have a really bad opportunistic infection. So let's go to the next slide. So acute HIV, as I mentioned earlier, the symptoms are very nonspecific. Most of us call it a flu-like or mono-like illness. And not everyone develops symptoms actually, because a lot of people don't come to healthcare, so we don't even know if they have symptoms. So about 40 to 90%, depending on the study you look at, people have symptoms. It's self-limited, it goes away after a while, so that's why we miss it. And most people go to the ER, they get tested for strep throat, for mono, for this and that, but then nobody tests them for HIV, unfortunately, and that gets missed because there's so many things that we make in our mind about how difficult HIV testing is, while it actually is not. And we have a wonderful case for you today to demonstrate that, and we have wonderful discussants to talk about that. But the symptoms are listed here: fever, lethargy, myalgia, maybe rash, headache, pharyngitis, adenopathy. So again, very non-specific symptoms. Next slide. So early signs to look for: thrush. If somebody has thrush, think about HIV. If somebody has this weird rash around their beard and hair and scalp, think about HIV in those people. That is called seborrheic dermatitis. If somebody has recurrent zoster, shingles, think about HIV. Something is wrong with the immune system in that patient. Next slide.
Everyone, it looks like Dan has his hand up right now.
Yes, so I'm almost finished. I'll hand it over to Dan pretty soon, but just wanted to kind of mention, if you can go to the next slide, that we will have more sessions addressing opportunistic infections. And we really want people to know those, because that's another opportunity where you can actually catch somebody with HIV. So keep in mind that there are some opportunistic infections that happen later. The ones that I want you to get your attention is pneumocystic pneumonia. That's one of the most common ones we see. Kaposi sarcoma, which can affect the skin. So if you see somebody with those infections specifically, it is HIV until proven otherwise, because they don't happen in other immunodeficiency states. So we're going to move on now to our case discussion. So Dan Cramer, or one of our nurse practitioners or PRNs at the HIV clinic, will be discussing our case and presenting it to our subject matter experts, Nakia and Laura. And thank you so much for your time. And we're going to stop recording now, because we would like people to take their time and freedom when speaking about this case discussion. We would love for you to unmute yourself and discuss the case with us. So over to you, Dan.
Thanks, Dr. Fadul.